now. And okay,
Okay,
so
we ready?
Dr. John, all yours.
Okay, we all set? Okay,
Yep.
so tonight, 802 Smiles, Caries Prevention and Arrest. I just point you to that subtitle that's above the main title, the why and the how for non-invasive clinical protocols in the school-based program. Next. Okay, so what are we going to do tonight? We're going to talk a little bit about the causative factors of dental decay. Going to list the preventive and therapeutic protocols that you can use in a school-based program. Identify the common locations that you're going to find dental decay, and how we can deploy these therapeutic materials, and also talk a little bit about some educational topics. Next. Okay, first and foremost, our mantra: we need to put out the fires. And this is a quote from a good friend of mine. Deborah knows John. Dr. John Fricella is a dentist. I would consider John one of my mentors. And I remember at some point 4 or 5 years ago on a Zoom with him or in an email thread, he used this phrase. First, we need to put out the fires, and the point here is that um, oral disease, primarily dental decay and periodontal disease, is really rampant. And when we find it in people's mouths, we have to. It's nice to like jump ahead and think about doing all sorts of, fancy and very complicated restorative care. But the first thing we have to do, we have to understand why we have the dental disease and realize that most of the dental disease that we have are bacterial based, and they are infectious. So the first thing we have to do is we have to quench the fires. Next. Uh, could we classify dental decay as a pandemic? I don't know. Strictly what the definition of a pandemic is, I'm not quite sure. But in our country, we know that 80% of all the decay can be found in 20% of the population. And we can figure that that's the lower socioeconomic groups within our country. The number one chronic disease in children is dental decay worldwide. You can find dental decay, untreated dental decay, in half the population over age 50. Children and dental decay in children, it's 5 times more prevalent than asthma. Now, I'm not suggesting that we should really highlight dental decay as a really a major problem within the pediatric community. It certainly isn't life threatening, but we all know that it can be very devastating. It can really be a social stigma, and it can really act and retard many children in their growth and development through life. The number one reason for children going to a school nurse today for pain is usually a toothache, is oral pain. That's the number one reason for visiting a, a school nurse for pain, is usually dental related. Next. Why should we be doing all this? What's so important about this? This is a quote from Dr. Joe Frenken. Dr. Frenken has spent most of his life studying and researching dental materials, primarily uh, uh, glass ionomer materials. And I think this quote really says it all. Too many people worldwide suffer from the consequences of untreated dental decay. We need to do something. A change is needing. We need to look at dental training institutions, dental schools, dental hygiene schools, and we need to really think about departing from the traditional drill and fill methodologies for treating this disease and grasp some of the really, really effective therapeutic agents that we have today and employ minimally invasive care, MID, minimally intervention dentistry. Next. Okay, causative factors of dental decay. We know that it's basically a bacterial infection. That's a point that very often is sidelined. We forget the fact that it is caused by bacteria. And you mix in some simple carbohydrates, and it doesn't necessarily have to be sugar. Um, I think about my friend John Fricella. I just mentioned a few slides ago. John Fricella goes absolutely bonkers when you start talking about goldfish. He that's one of the yeah, I know Debbie, you've probably heard him in his
Yeah.
lectures, but you know uh, saltine crackers, white bread, any simple carbohydrate is going to, especially if it's sticky and it sticks to the teeth. I mean, that's as bad as sugar, if in some cases maybe even worse. So the results of this, you're going to have the simple carbohydrates are going to be metabolized, and you're going to produce acids and enzymes. And the acids are going to break down the calcium hydroxyphosphate of the enamel. And if you, Jamie, you remember calcium, I talked about this when I was there visiting with you. Calcium hydroxyphosphate is AKA hydroxyapatite. I do not like the term hydroxyapatite because it really doesn't tell you what it is. Calcium hydroxyphosphate tells you what it is. It has calcium in it, it has phosphate in it, and knowing what the tooth is made out of is very helpful, particularly when it comes to understanding some of these materials that we're going to be talking about tonight, particularly glass ionomers. The enamel is 95% calcium hydroxyphosphate, and it's important to remember that the dentin is 70% calcium hydroxyphosphate. So many of these materials that we're going to talk about tonight, not only will they ionically bond with the enamel, but they will also ionically bond with the dentin. And generally in, in, in dental education, we are taught that there isn't anything that really um, can have an interface with dentin, but glass ionomers can ionically bond with dentin. The enzymes will break down the collagen, which is the other 30% of the dentin. Next. Depth of knowledge. This is something I hammer on, and some of you that have been around and you've heard my lectures over the years. You know, I'm a real stickler for this. It's really, really important to have a significant depth of knowledge. It's easy to learn how to do something. We can teach. I remember, and I know you're all dental hygienists, and I don't want you to get insulted with the first part of my statement, um, because the second part of my statement is much more important. I remember when somebody said, we can teach a monkey how to use a scaler and a curette. And that may be true. I don't know. But what we cannot teach monkeys, and what we cannot teach, only what you can learn is, why did you spend 3 years in dental hygiene school? How long did it take you to learn to use a curette and a scaler? It didn't take you 3 years. It's the basic scientific knowledge that you gain in your educational endeavor that is really, really important. This is what helps you to understand why you do what you do. And if you understand why you do what you do, you will find it will be much easier to explain things to patients and to educate patients. I remember once in uh, a staff meeting we had staff meetings once a month, and it was one of my hygienists, a fresh young face right out of dental hygiene school. She had been in the practice for 1 year, and she looked at me and she said, Dr. John, she said, we spend half of our time educating our patients. Half of the time that you spend in your professional career is going to be having conversations and educating people. That's why it is really, really important that you really have a significant depth of knowledge. Next. Okay, again, to repeat, remember, dental decay is a bacterial infection. Streptococcus mutans, lactobacillus, actinomyces, there are the three biggies. There are some other ones that are also can be cariogenic, but it is important to point out here that all of these are anaerobic bacteria. Really quickly on a side note, Deborah, did you get an email today from Mike about that strain of Streptococcus that was being developed? Did you get that email?
No,
I
I
got a
don't.
really
If
cool
I
email.
did, I haven't read it yet.
One of our 802 Smiles dental hygienist Mike Messina, he sent me an email today, and he found an article where someone was developing a strain of Streptococcus mutans that would not produce acid, but it
Mm,
would produce ethanol. I don't know. Is that
wow.
something anybody hear about? And the point being is, and if you put this, the studies have shown if you put this bacteria in, I guess they were doing it in probably in rats or mice, they were finding that this new strain of Streptococcus was replacing the old strain of
Mm,
Streptococcus, and you were basically ending up with a mouth that was could be almost completely acid free. I thought that was really
wow.
interesting. I haven't had a chance to talk to Mike about that, but I want to find that article.
Interesting.
But anyway, I'm sorry I jumped off the topic there a little bit, but it is a bacterial infection, and these are the three biggies. Next. Okay, biofilms and dental decay. It is important to know that that all these bacteria that we're talking about, they are part of a biofilm, a bacterial biofilm, and there's lots and lots of different kinds of biofilms all throughout our body. Most of the biofilms in our body are harmless, but in this case, the biofilm that you can find, these bacteria in, are definitely a pathologic biofilm. There's some really, really good articles about biofilms. If you look at the very bottom of that slide, there's a website, www.mmclibrary.com. There are some there's a whole bunch of really good articles there about all of the things we're talking about tonight, but they have some really good articles about biofilms. I get into detail about biofilms in my other programs. I'm not going to get into it tonight, but it is important to know that biofilms can be very, very protective of the bacteria. And most oral rinses that we use, which would also include chlorhexidine, they do not penetrate the biofilm, and they will not kill the bacteria within the biofilm. Silver diamine fluoride will penetrate the biofilm, and I'm going to also talk briefly about povidone iodine tonight, and povidone iodine will also penetrate the biofilm and kill the bacteria. Next. Other therapeutic medicines. Okay, so basically there are four essential medicines that we could use in a school-based program. Essential is a specific term. It defines a certain type of medicinal agents, and this definition has been used by the World Health Organization. It's also used by the FDA in this country. Both SDF and glass ionomers and povidone iodine are all classified as essential medicines. And to be an essential medicine is really important. It has very strict criteria. It has to meet. It has to be very effective in its action, and it also has to be very safe for the patient. So that's nice to know that all the things that we're talking about tonight are basically safe for our patients, and we don't really have to be concerned about using them on our patients. The four essential medicines used: fluoride varnish, silver diamine fluoride, povidone iodine, and glass ionomer cements. Next. Okay, so where do all these little bugs and interlopers lurk within the mouth? Permanent molars, 90% of all early decay can be found in the pits and fissures of the occlusal surfaces of permanent molars. Primary molars, 44% of the decay can be found in pits and fissures.
By the way, this is John.
Sounds like
Hey,
John.
Mike, how are you?
Hey,
Oh, I didn't realize you were actually.
I didn't know I didn't see on there. Did you hear me talking about you earlier?
let me see if I can control shift.
No, never mind. Anyway, I was telling stories about you, Mike. But good thing
Can you hear
wanted-
me?
Yes, you're fine.
Yeah, yeah. No, I was here and I heard you and I didn't want to interrupt, but
Okay.
yeah. I mean that article is really great. I actually just sent it to Deborah, and
Great.
you know, it actually was discovered in the 80s by a Dr.
Really?
Hilleman, and yeah, I mean it's not FDA approved, you know but so yeah, just interesting read. That's all.
Mhm.
I'm gonna look forward to looking at it. But anyway, primary molars, we know that, I know I can only speak from my anecdotal experience. You know, I usually found dental decay usually inapproximately on primary molars, but it doesn't necessarily mean that we shouldn't do something possibly to treat the occlusal surfaces of primary molars to prevent decay. Very important point, that third box down, very important point to make here. I mentioned earlier that a tooth is made out of calcium hydroxyphosphate, but when the tooth is young and newly erupting, like a 6-year molar, and it's just coming up through the tissue, it is not made out of calcium hydroxyphosphate. It is made out of calcium hydroxycarbonate. Now, the reason I'm making such a big deal about this here is because when we, in a couple of more slides, we're going to start to talk about glass ionomer materials. And the important thing to know is that the calcium hydroxycarbonate, this newly erupted tooth, over time, the saliva will replace the carbonate radical with a phosphate radical. And then the tooth becomes, you essentially have immature enamel in a newly erupted tooth, and it takes time for that enamel to mature. And we've heard this talk about immature enamel, mature enamel. And the reason is because the immature enamel has a carbonate radical in it, not a phosphate radical. Carbonate radical, the tooth is I hate to use this term, but they talk about, you know, it's a little bit softer, it's a little bit more easily invaded and a little bit easier to break down. So it would be nice if we could, as soon as a tooth comes into the mouth, if we could accelerate the maturation process on the tooth and make it more resistant to decay. Glass ionomer materials and silver diamine fluoride will help to accelerate the maturation of the enamel. Composite resin sealants do not help to mature the enamel. In fact, when you put composite resin on top of a newly erupted molar, you will actually retard the maturation process because you are preventing saliva from coming in contact with the enamel on the occlusal surface, and you are not allowing it to mature the enamel. This is another reason I do not like composite resin for sealants. But if you put glass ionomer on top of that tooth, you're going to accelerate the maturation and you're going to make it more resistant to decay. Okay, preventing includes killing the bacteria and accelerating the maturation process by replacing on the calcium hydroxyphosphate. You're going to be taking out the hydroxy radical and you're going to put in the fluoride element. So you're going to get calcium fluorophosphate, just like they talk about hydroxyapatite versus fluoroapatite. Fluoroapatite is calcium fluorophosphate. And I know it's late at night and I'm getting really nerdy with the chemistry and I'm really sorry, but I just hang in there with me. Okay, next. All right, so where do we go? What do we do? And how do we start doing this? Well, you all know this, but you all know this way better than I do. But you start with a prophy, a toothbrush prophy. Most of us do. You get in there, you identify decay. Hopefully you will have parental permission to do what you need to do. And then you can treat all the posterior decay only with SDF. Please do not use SDF on the anterior teeth. It isn't going to hurt them, but we all have used SDF and we know that it will stain the decayed portion of the tooth and it can really make the tooth look unsightly. And we get negative feedback from parents because of that. When I first started using SDF back in 2012, the first week I used it, I think it was the second patient I used it on. I put it on some anterior teeth on a 4-year-old, and the mother came back a week later. I had to complete treatment, and the mother looked at me. She said, "You're not going to do that on my daughter today." And I said, "Oh God, I made a mistake." So please do not use it on the front teeth. We worked through that. Actually, my dental assistant worked through that issue with that mother. I wasn't equipped to do that, but my dental assistant, God bless her, she was good enough, and she she talked the mother down, and we continued with treatment. But anyway, so don't use it on the front teeth. Only use it on the posterior teeth. If you have access to glass ionomer materials, just kind of off the record here, you can use glass ionomer in the anterior. You can skim coat those decayed areas with glass ionomer, and you will get pretty significant caries arrest from that, and you won't be discoloring the teeth. If you have the pink stuff, obviously don't put it on the front teeth. That would be as bad as putting SDF on almost. Anyway, okay, so you're going to put SDF on the posterior teeth only. After you put SDF on the teeth, then you're going to put fluoride varnish over the SDF. You're going to keep it isolated for a minute, and then you're going to dismiss the patient and give them the proper post-op instructions. Or before you apply the fluoride varnish, with permission, you can do the sealants on the teeth and then cover them with fluoride varnish. So we were talking about using SDF. Now we're talking about doing sealants. So if you have permission to do sealants in those teeth, don't put the fluoride varnish on, obviously. Do the sealants first and then cover them with fluoride varnish. If you suspect that there might be possibly even just the slightest little bit of decay on the occlusal surface of that tooth, I would recommend that you would treat it with SDF first and then do the sealant. And we're going to talk about protocols for doing those things in just a little bit. Next. Okay, here we are, clinical protocols. You all know how to do fluoride varnish. You can do it better than I can do it. I know you can. After you do the toothbrush prophy, okay, I've talked about using povidone iodine here. You can skip step number 2, but after you do the toothbrush prophy, you want to apply the fluoride varnish directly onto the teeth as directed by the manufacturer, and give the patient post-op directions and dismiss them. Next. Clinical, I think you skipped one, Deborah.
Oh, did I? Let me go back.
Yeah.
Sorry.
Okay, clinical protocol
Yes.
for SDF. Okay, after you've done the toothbrush prophy, wipe the teeth clean, dry them as best as you can, the caries lesion as best as you can. Keep it isolated, keep it as dry as you can. Apply a small microbrush of SDF onto the lesion. Take the microbrush and scrub the lesion with the microbrush. You don't really need a lot of SDF, but you really have to make sure that you get it on the carious lesion and you get it into the dental decay area, and then immediately cover it with fluoride varnish. Continue to keep it isolated for at least a minute, and keep saliva and moisture from getting on it for at least a minute. And then you can dismiss the patient and just give them the post-op directions that you would normally give for fluoride varnish. Next. Okay, clinical protocol for glass ionomer. So this would be straight, going right to the tooth and doing a sealant. You haven't done any SDF at all. So we're going to start with just doing a straight glass ionomer sealant. The area's got to be clean. Make sure the occlusal surface is clean. You want to isolate the tooth. You want to dry the tooth. You really want, there are times when you want the tooth to be dry, and there are times when you want the tooth to be not dry. This is the time when you really want it to be as dry as you can get it. Because after you've dried it, you want to put the tooth conditioner on the tooth. The tooth conditioner is extremely important to use, everyone. The tooth conditioner is a liquid, and essentially what it is, it's the polyalkanoic acid part of the glass ionomer that you're going to be putting on the tooth. But what it does, and I'm not going to get into a lot of detail here, but what it does, it literally will activate and excite the molecular structures of all those calciums and all those phosphate groups that you have in the calcium hydroxyphosphate, and it gets all the electrons buzzing around, and then you're going to wipe it off, and then you're going to get a much better ionic bond, ionic connection of the glass ionomer when you put it onto the tooth. So that's why we use the tooth conditioner, and that's why it is so very important to use it. It is, though, very important that you remove as much of it as you possibly can, because if you leave too much on the tooth, then you're going to change the acid-base balance of the glass ionomer, and you won't get as good a fusion to the tooth, and you won't get as strong a glass ionomer. So you want to really wipe it off as best you can. And for those of you that, if you take my sealant course, I get into the details of how to do this, and then when I demonstrate it, I show you how to do it. So I'm not going to get into a lot of detail here, but you got to make sure you get as much of the tooth condition off as possible, but you want the surface of the tooth to be moist. Glass ionomer is a hydrophilic reaction. You have to have some moisture in the tooth. I don't want it to be underwater and saliva, but I want it to be moist. I want it to be glistening with moisture. Mix your capsule for 7 to 10 seconds. 7 seconds is adequate. The reason that if you look at the instructions on the packaging, it'll tell you to mix it for 10 seconds. Everybody says to mix it for 10 seconds. I got it straight from the manufacturer from the R&D department at GC America. 7 seconds is adequate. The reason that I mentioned 7 seconds is because if you're doing this in the school and it's a hot day and you're in a hot room, this glass ionomer is going to set up really fast on you. And if you mix it for 10 seconds, you might not get it from your mixer onto the tooth and into the occlusal surface quickly enough. If you mix it for 7 seconds, you're probably going to add, at least 7 to 12 seconds of working time. And that may not sound like a lot, but it can be enough to make the difference between a successful sealant and not a successful sealant. So anyway, you're going to mix it and you're going to squirt it on top of the tooth. You're going to squish it into the tooth. You only have 30 seconds. As soon as you hit the button on the titurator and it starts to mix, you have 30 seconds. You're going to mix it for 7 to 10. You're going to put it in a squirt gun. You're going to get it on the tooth. You're going to squish it in the tooth. At 30 seconds, you want to stop manipulating the glass ionomer, because from that point forward, it's starting to set up and you can weaken the cross links in the glass ionomer, and you can make it weak and possibly lead to the failure or the glass ionomer coming off of the tooth. It is really important that you keep the glass ionomer moist for the 2.5 minutes that it sets up. Next. Okay, some important points about everything I just talked about. Number one, the lesion must be moist when you put the glass ionomer on it, not dry. So if you have access to an air syringe, you don't want to be blasting with air and drying it real dry. You want it to be moist when you put the glass ionomer on it. As I mentioned just moments ago, please always use the tooth conditioner as directed. You're going to get a much more successful sealant if you do that. It is really, really important that you clean off the margins around the sealant, clean off any excess material after you put it on. Again, do not manipulate more than 30 seconds. You must keep it moist and wet during the set period, which is about 2.5 minutes. And it is important. That's okay.
I'm
And it's
sorry. Let me
important.
see what happened here. I'll try
That's
to
all
go
right.
back, Dr. John. This is acting weird.
That's all right.
I'm going to go back. Sorry.
Right.
There.
All right. The last box isn't terribly important, but particularly for sealants, but it's really would be advisable to tell the patient not to chew in the tooth for 2 days. Trying to tell a 7-year-old not to chew in the tooth for 2 days, it's not going to work. So anyway, how do you get around that last box down there in the bottom right? Emphasis and post-op direction. All right, less is better than more. When you put your sealant on, when you squirt, for those of you that have done composite resin sealants, you know that you can take that little teeny syringe and you can just put a little tiny squirty bead right across and you can squish it in there. It's different when you're using the applicator gun for the glass ionomer. It's going to be this huge glob is going to come out on top of the the occlusal surface. Less is better than more. You don't need to put much up there on top of the tooth and then squish it in with your finger. After you've squished it in with your finger, you want the patient to bite, 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 chomp, chomp, chomp. You want them to bring that into occlusion, and any excess material gets squished up and out. Then you want to clear off around up over in the cusp areas, clean off all excess. Less is better than more. We've had conversations with dentists, and there have been reports of putting too much material on using too much sealant material. It isn't a
Kevin, you need to
tragedy.
be
You
quiet.
have to use some amount of grace when you do it. Some amount of finesse. You can't just
Barry,
like push it
I-
side to side. Do you get what I mean?
hello?
Mom, I need to understand that you understand what I'm saying.
Oh, Barry,
Okay.
you're not on mute, sorry.
So anyway, I think the next slide, I think I talk about it in the next slide. Let's see what this next slide says.
Okay, next slide.
Yeah. Okay, no. Okay, this is important. Talking about using glass ionomer for sealants. Really good study found that 93% of glass ionomer sealants were successful at preventing decay after 4 years. The measurement that we use for success with a sealant is not whether or not we look in the mouth and we see it stuck to the tooth, but whether or not it prevents decay in the tooth. And we have found that glass ionomer sealants, so far in the long-term research that's been reported, that glass ionomer seems to be superior to use than composite resin, even though you might look in the mouth and you might see that some of it's been knocked off or broken off, but it's down in those grooves, pits, and fissures, and it has bonded to the tooth. It's also important to note that when you use glass ionomer as an indirect pulp cap, which may be the case later when if any of you are interested in taking the training program for doing smart restorations, which will be coming up sometime this year. Putting glass ionomer on dental decay is safe for the pulp. It will not in any way harm the dental pulp. In fact, it's been found to be very successful as a pulp capping agent post-op for 3 years. Next, Deborah. Okay, really quickly, just want to talk about povidone iodine. Povidone iodine, also known as betadine. You guys don't have it in the school, and we're not going to be using it for a while anyhow, but I think it's nice that you know about it. Povidone iodine, generally, when I use it, when I've used it in clinical situations, you put the povidone iodine before you put on the fluoride varnish. Easy to put on, just put it on with a Q-tip. After you put it on, then you just immediately cover with the fluoride varnish, and you dismiss the patient with the normal post-op directions for fluoride varnish. This is for clinical use. Deborah, you want to go to the next slide?
Yep.
For at-home use, using povidone iodine at home, very easy. Just brush, floss, get your mouth nice and clean. Just take a Q-tip. I haven't changed these, Deborah. We have to change these. We got the new information from Jeremy Horst. But anyway, I'll mention it here. Anyway, just get the teeth nice and clean. Take a Q-tip, dip it in the povidone iodine, put it around on your teeth. Now, the protocol that we got from Jeremy about 3 years ago was to apply it once a day for 7 days and then apply it once a month from that point forward. But in the new research he's doing, Deborah, you saw that. Did you see the new Elevate Oral Care webinar that he did?
I don't recall any the recent.
Well,
No, not the
it's
recent.
it's pretty new. It's only about 2 months old, but in the new research, he says once a week for a month and then once a month. Less is better. Yeah, that I know. I picked that up when he was doing that webinar. I thought that was interesting. But you do it once a week for a month, in other words, 4 times, and then after that, you just do it once a month. Less is better than more, because the more diluted the povidone iodine is, the more release of the iron there is, and the greater the capacity for killing bacteria. You can cover. I got this next little hint. I got this from a pediatric dentist that I know in New Hampshire, um, Dr. Johnny Norris. But he tells his patients when they do it at home to then take some toothpaste, or if they have Prevident 5000, and just lightly coat your teeth with the toothpaste. Because normally, if we did it in a clinical situation, we would be covering it with fluoride varnish. But I remember when Johnny and I were talking about this one time, and he said, "Oh yeah, he tells his patients just to like just skim coat it with a little toothpaste. It's going to wash off in 10 or 15 minutes, but it's going to do the job. And the important thing is not to rinse." Now, again, I want to repeat, this is not something that we're doing in the program. And this slide and the one previous to it, I just wanted to give it to you all, just as a edification for all of you. But we're not doing this yet in the program.
May I interject something?
Yes.
Sure.
One of the things Elevate came and they gave me some samples of their POVI one, and then I watched their educational video. One of the things I tell my patients to use is the POVI is 8 drops is what they said, I think, in the video. Just it's a way to control like how much they're using. When people are like, well, how much? And I tell them 8 drops of the iodine in a cup, and then you stick the Q-tip in once until it absorbs it all, and then you're done. Because I think, we're all like, oh, a little bit more and a little bit more. So for me, that's one of the things I am telling my patients. 8 drops, 1 Q-tip, wipe it around, you're done. Just a little thing I do.
Thank
Sarah,
you.
I want to talk with you on Friday about that, because I've never used any of their I've never used their povidone iodine product. All I've ever used is what I buy at the drugstore, just a bottle of PVPI, and I use that. But
we probably won't purchase it, but we bought a ton of stuff from Elevate, and so she's like, well, here, have these free samples. So we got like a box of free POVI ones, and so we just a couple of our patients, we knew immediately who we wanted to give it to, and we just gave it out for free to our clients at the dental office I work for. And like, hey, try this for 6 months. And one of them was a microbiology student at UVM. And she just has rampant decay with really good oral hygiene. So she's going to be really interesting. And when she comes back after 6 months to see, because she's one of those people every time, decay. Why? She understands how everything happens. So she's my one that I'm super interested to see how it works.
Sarah, this is interesting. I want to talk with you at length on Friday when I come to do the on-site visit. But this really is interesting. Now, this is a patient that has good home care. I'm sorry to jump off on a tangent here, people, but I think this is important because it brings up something that I've been wanting to get into the program. And Deborah, we talked about it a little bit, but it's a really simple thing. But so this is a patient, Sarah, that has a lot of decay, but they have good home care. Did you ever do a pH test of their saliva?
No, we were talking about that. We have not done a pH test of her saliva. No. She's currently just my patient this one time. This is the first time I met her, but she's been a long-term patient of my doctor's for a while, but it would be interesting for sure.
I took a bunch of courses at Yankee this year with a guy Brian Novi, and Brian is a very interesting fellow. If you ever get a chance to go to any of his lectures, I guarantee you will not fall asleep. Yeah. Not at all. But anyway, he's really big on pH, and he actually gets and I have some. If I remember, I'm gonna bring some paper with me on Friday, Sarah, and I'll give it to you. But he has a little $8 roll of pH paper, and Brian's really big on testing everybody's pH. He said, I don't care how good they brush and floss, if they have an acidic mouth, they're going to get decay. So you have to think about how do you change the pH of the mouth in order to really reduce decay?
Yeah,
And sometimes it's more than just brushing and flossing, but
Yeah.
anyway, that's
for sure,
something-
definitely.
that's something that again, I'm sorry to hop off
No,
topic here a little
it's
bit,
interesting.
but I think that it's something that we ought to think about doing at some point. Okay, next, Deborah. Okay, there is, as I mentioned, there is a really good PVPI seminar that Jeremy Horst does, and you can get it actually you can get it right on YouTube. I found it, but you can also, if you go to Elevate, you can get some CE credits. Elevate Oral Care website. They have free webinars, and you can get CE credits for that. They have a lot of good stuff at their website. So does GC America. They have really good free webinars, and you get free credits. Next. Okay, educate. Who do we educate? Who do we target? Everyone. We should be dental missionaries, everyone. Our school nurses, I cannot say enough good things about our school nurses. You guys know it better than I do, how important it is to have a really, really good school nurse. All of the on-site visits I've done this year, I'm overwhelmingly impressed with the enthusiasm that I've seen coming from the school nurses. They are really, really important because they are really the link to me communicating with the caregivers and the parents of your patients. And you guys probably know this better than I do. Also, our teachers, we should really think about how well we connect with our teachers. During COVID, I helped Alice Peck Day Hospital do their school-based programs. I did 5 schools, and I learned an awful lot about school-based programs when I did these. And I remember I was at one school, and of course I was there all day, and I was talking to the nurse and talking to teachers. And I remember talking to these 2 teachers, and because it was during COVID, they stopped doing that little show and tell you guys do. You know, you go into the classroom and you give the little, with the little kids, and you do show them how to brush and the cavity creeps and all that stuff. These teachers, they said that was one of the most valuable things that they saw the dental hygienists do. They said when the dental hygienist would come into the school, into the classroom and give the lectures, the kids were just all ears. And when they talked about diet and they talked about food and foods they should eat, should not eat, these teachers said they actually saw dietary changes in some of this children's eating habits. So you guys, when you go into the classrooms, let me tell you, it's really, really valuable, and you're really doing a great service, and you're really, really, it's really a great educational effort. So don't think that you're just going in there and you're running through a bunch of pictures and playing with toothbrushes, because it really is very valuable for the kids. What do you guys think? What have you, for those of you that have been in classrooms, have you found it to be, do you think it's helpful? I'm asking you all this, so feel free to speak up.
It makes me not want to be a teacher. No, it's great. I actually have one more classroom to visit this year. I think I have 8 classrooms in all that I visit in my Head Start program. But yeah, the kids, it kind of depends on the classroom or the group, really. This year's been really fabulous, and the kids are enjoying the program that I did this year. I try to do it different at least every other year, because we have kids are 3, 4, and 5 in this classroom. So try to do something different every year. And this year I'm doing, I've had a lot of kids who are having behavioral issues at the dentist because they're scared or terrified. So I've been bringing in my dental kit that I use, and I bring in my polishing and everything. And we kind of talk about that. And we talk about, I have a book that I read, and then we make a toothbrush and stuff like that. But I think it just, for my early Head Start, or for my Head Start kids, it just depends on the classroom. But I mean, once you get in there, they're pretty cute and fun.
Yeah,
Yeah.
I used to do it when I was in practice. We used to go down to the local elementary school, and during
Mhm.
dental health month, and we would visit. It was, yeah, I agree. It was really a lot of fun, but I'm glad I'm not an elementary school teacher. Absolutely, I have to. Yeah, got to have a lot of energy, boy. I'll tell you. Wow.
Mhm.
For my
Okay.
Head
Yeah,
sorry.
go ahead. Go ahead.
For my Head Start classrooms, I go in 3 times a year and do that. And the first time I read a book and do an activity about going to the dentist. And the second time is about brushing and flossing. And the third time is about nutrition. And I do that in all of my Head Start classrooms. And then in the elementary school, I go in each grade and do a video or a book that's age appropriate. And then I have an activity, and that's what I do. And it's great. And yeah, I don't envy school nurses either, because they don't have time to even eat or go to the bathroom. Nothing.
Mhm.
It's insane.
Mhm.
Well, I'm glad you're using age appropriate books, Serena. That's really good. I can't imagine you could get an inappropriate dental book, but anyway, who knows? In this world today,
No,
who knows?
just that they would understand. Like, I'm not
Right,
going
I
to read
know, I know.
big words for little kids, you know?
Right, I know. I was being facetious. Shouldn't have said that. I was aggressive, but anyway. Anybody else? All right. I don't want to put anybody on the spot, but if you have anything, it's always interesting to hear these stories.
Mhm.
Okay, Deborah, next. Visual aids. If you haven't yet seen them, you really should go and see the 802 Smiles videos that they have on the website. They are really, really incredible. They are fantastic. I think you could use them kind of as an educational push, possibly, for trying to reach out to parents. They have 2 videos. One of them is a 7-minute version, and then they have one it's a little bit less than 3 minutes, and it's a summary of the 7-minute version. But they are really, really excellent videos. I know almost nothing about video production. I know enough to get myself in trouble, but I can tell you what it took. These videos are really, really well done, and it was really a great effort. So if you haven't seen them, go to the website and take a look at them. This can really sell our 802 Smiles program. I really think it can. Next. Okay, yeah, don't overlook patient education and the caregiver. It's really, really important that you be able to. It's hard to get to the caregiver in a school program. I found that to be the case when I did the 5 schools I did. It's not like I'm in my office where kid comes in, sits down in my chair, and the mother or the caregiver is in the room with me. It's really, really important to try to make sure that the caregiver or the parent understands everything that you're doing. Visual aids are always helpful. Handouts are always helpful. So it's really important that you do your best to don't forget about the caregiver and getting information to them. Next. Other educational resources. There's a ton of stuff at the 802 Smiles website. You can find, of course, the SDF handout. You can do for a child, and then you probably all figured out how to do this, but you can do a simple demo for the child. You can take a microbrush, dip it in water, and you can paint their fingernail with it to show them what you're going to do if you're going to put SDF in their tooth. We haven't yet started doing anything with povidone iodine, but there is a good take-home set of directions for that. And of course, I'm going to sick you all on Deborah here because we have plenty of stuff. And again, the website, if you guys haven't been to the website, please go to the website. There is just a boatload of stuff there that can be very, very helpful. Next. That's it. Any ideas? Any suggestions? Any thoughts? I'm open. This is as much a opportunity to learn from all of you. If you can think of anything, don't hesitate to send me an email.